Hi, Ajit, are you there? Hello, everybody. It's Wendy calling from BCDHA. I'm just waiting for our presenter to show up, and then we'll get started. Hi, Ajit. Let me know when you're on. Hi, Ajit. Are you there?
Yes, I'm here.
Ah, good. Thanks. Okay, I've just started to record and we'll get underway. So hello and good evening to everyone who's logged on this evening. Thanks for attending our webinar tonight. We really appreciate your attendance. Before we get started, I'd like to introduce myself, our speaker, and share some housekeeping information. Just letting everyone know we are recording the webinar this evening and we will make it available on demand at a later date. So if you're experiencing difficulties with audio or video, usually the best solution is to just log out and then log back in again. That usually will fix up any disturbances you're having. However, if you are really having trouble, we will make this available at a later date for on-demand viewing. So please watch for BCDHA communications on that. The next slide. There we go. So welcome to this webinar again. My name is Wendy Jobes and I'm your moderator for this evening. I am also the BCDHA Manager of Dental Hygiene Practice, and with me is your presenter, Ajit Johal. You should be directed to a survey at the conclusion of this webinar. And so please take a few minutes and complete this for us, as your feedback is very, very helpful for us. It helps us know what we're doing right, and if we're not doing something right, and we can change it. And oftentimes it's easy enough to do that. We just need to know what it is that's not working for you. Just a little bit about myself. I've been with BCDHA for several years now. I love my job. I get to connect with lots and lots of dental hygienists from across the province. And so yeah, I just really enjoy doing these types of events. I was an educator in a dental hygiene practice for 20 years. I currently work in residential care as well as for the association. I have 2 dogs and 3 grown children, one of which still lives at home as he's going to university. So thanks everyone for attending. The webinar is designed into 2 parts, a 45-minute presentation with our presenter and then 10 to 15 minutes for Q&A. Just a little bit about our platform here. We've just recently changed to the Zoom platform, so I'm going to review a little bit of it. Here, normally what you can do is you can see the settings, but you have to pass your mouse over it. They're usually found over top of, at the bottom of your screen or the top of your screen. And once you move your mouse over top of an area, then you'll see the settings pop up. You can check your audio here down at the bottom if that's where your display is coming up. Sometimes it might be at the top of your screen. If you pass your mouse over it, something like this should pop up. You can test your speakers. You can raise and lower your hand. We don't usually use those very much unless I'm asking how audio is, and people can raise their hands to let me know that things are okay. There is a Q&A box here. There's also a chat function, so you can add questions into the Q&A as well as add questions into the chat function. Here's the place where you would put in your questions, and then you just hit send. Everybody should be able to see everybody's questions, and there should be an upvoting. Like you can put a thumbs up to a question and it'll rise it higher. And if lots of people are giving their thumbs up, it'll come up higher for me to see. Next, just a reminder that you must log into your CDHBC online learning plan and add this particular activity to your list of activities. BCDHA does not offer certificates, so the best suggestion is to keep your registration information, possibly an email that you might have received, your handwritten notes, or anything that you may have kept to indicate that you attended, and any other documentation that might demonstrate your learning to the college. CDHBC has also made it possible to upload electronic documents. So you can certainly scan and house this type of information directly in your online profile. I noticed with the revisions that they recently did, that's very convenient. I don't even have to keep a hard copy file anymore. I can just scan those documents in and upload it into the platform, and there they are, and they will live forever. And remember that the suggestions we make for CE credits are just that. They are a suggestion. It's up to each member to decide how this event best fits into your own particular professional development and learning needs. So here we have, we're just going to do a poll practice. I know our last webinar, we were experiencing some difficulty with the polling, so we'll see how it works tonight. Here, I just want to pull up our test poll. So I'm going to launch this poll. You should be able to see the first question. It says, which is your favorite, coffee, tea, both, or neither? And there I can see people coming in. So far we have 181 participants logged in, so that's pretty good. We had over 350 registered, so that's great. So you can see it's easy enough to change your answers. You can make a choice. Okay, I'm going to end polling here in 5, 4, 3, 2, 1. Okay, and then I'll share the results. Coffee was the winner by a fair margin. Great, so that seems to be working for most people. So I have another poll here. This comes right from the presentation, and I'm going to launch it right now just before I introduce Ajit. So the question is, in the 20th century, it is estimated that smallpox resulted in 10 to 20 million deaths, 50 to 100, 100 to 200, or 300 to 500 million deaths. So I'll give everybody a few moments there just to see if you can maybe take a guess or what you think might be the most accurate answer to that question. Okay, and I'm going to end polling here in 5, 4, 3, 2, 1. And I'll share the results. Looks like 500 to 100 million deaths, definitely won by quite a margin there. So we'll see. I'm not going to give you the answer. I know I've seen the presentation, seen the slides, so I'm not going to share. I'll let Ajit share that, so I'm going to get rid of that. Next. So this is our presenter, Ajit. He's been providing immunizations and clinical education since 2012. As a community pharmacist, he is an accessible provider of immunizations to patients in the community. In 2018, he started an organization called Immunize.io with a mission statement of taking our best shot at immunizing the world. Through Immunize.io, he has worked with numerous organizations and communities to improve education and reduce barriers to vaccination. Ajit is also a clinical instructor at the University of British Columbia, faculty of Pharmaceutical Sciences program. At UBC, he coordinates elective courses for UBC pharmacy students, one of which focuses on vaccinations and gaps in immunization. So without further ado, I will pass the reins over to Ajit. So thank you and welcome. And I'm just going to have to stop sharing so that Ajit can bring up his presentation, and we'll let him take over. Thanks for coming and speaking with us this evening, Ajit.
Thank you, Wendy, and thank you to all for spending your evening learning, which is always good. As a fellow healthcare professional, there's always so much that we need to know, so good to stay on top of it. And thank you, Wendy, for facilitating this. So I am a pharmacist, and my area of interest is immunizations, and today's presentation is about a global health phenomenon called vaccine hesitancy. And in particular, we're going to zoom in on what dental hygienists need to know. Okay, so just a bit of disclosures to start with. I do have consulting with numerous organizations like the BC Pharmacy Association and numerous medication manufacturers and biotech companies as well. For today's presentation, there is no commercial support to declare, so this is strictly on my own volition and passion for the subject. So Wendy did mention my biography. I've got a couple immunization-focused practices, including TravelRx, which is a network of travel immunization clinics, and Immunize.io, which is a nonprofit organization with the mission statement of taking our best shot at immunizing the world, where we support community immunization initiatives through education, outreach clinics, and donate our profits to developing countries where those who are less fortunate don't have access to the immunizations we have here, and we still see a lot of deaths from vaccine preventable disease. So today's learning objectives, so you'll notice there is some teeth in the learning objectives because this is a presentation for dental hygienists. So although my area of expertise is immunizations, I hope that you can come away with something for your own practice. So here are the learning objectives written in CE format, basically vaccine hesitancy on global health, 3 domains of hesitancy, immunization gaps in adults, and then looking at this concept of recommended but unfunded vaccines. So new vaccines coming on the market that unfortunately the government only spends less than 1% of the healthcare budget on vaccines. So there are some vaccines that are highly recommended for specific demographics that are currently not covered. So that's something that a misconception that a lot of we need to tell our patients about. And of course, at the end, we'll talk a bit about travel vaccinations when traveling abroad, because I'm sure there's members in the audience who do some traveling. So we started our presentation with a little story, and we call it 12,000 Years of Terror, and it's a history of the smallpox virus. So there's a picture of the smallpox virus, and it's been around actually since the 3rd century BC. You can see there's a mummy. There's a picture of a mummy here from the CDC website. That was the first sort of documented case of smallpox infection in humans. Now, smallpox was a devastating illness. We talked about 12,000 years of terror, and it was quite a nasty disease where individuals who were infected by it would develop these blistering rashes all over their body, mostly on the extremity of their hands and their feet. And these are sort of a picture of the rashes. And I apologize if anyone's eating dinner at this point in time, because some of these images may be disturbing. Smallpox left a lot of its victims blind. So it was a cause of blindness and, of course, a cause of death, leading to 300 to 500 million deaths during its 12,000 years of terror. So along came a scientist by the name of Edward Jenner, who found that the milkmaids on the farm would develop some sort of immunity to smallpox because of their exposure to cowpox by milking the cows. So what he did is he took his gardener's son and basically took a glass rod and poked him with cowpox and exposed the boy to smallpox. Now, this type of study would not be condoned today. There's much more sophisticated randomized controlled trials when we test vaccines. But this was the development of the first vaccine against smallpox, and the inventor was Edward Jenner. This led to the global smallpox eradication, starting with North America, and then ultimately ending up in Asia and Africa, where in October 12, 1977 was the last known case of smallpox in the world. This is actually the patient. This is a young child from Bangladesh, which was the last village human to have been infected with smallpox. In 1979, the World Health Organization celebrated smallpox zero, meaning that this disease was eradicated from human existence. Now, this isn't the only successful vaccine in the 20th century. You can see there's many vaccine preventable diseases that contributed to multiple deaths in the 20th century. And now in 2013, when 2013 reported cases, we see significantly less, and you can see decreases across the board. Life expectancy at birth. So in 1840, nobody was living past their 40th birthday on average. Now we're seeing that almost double, and vaccines is the public health intervention that has been a key contributor to humans living longer. So now in 2019, where are we at today? So we took our little lesson in history. Where does that bring us to today? unfortunately, we are starting to see a bit of a regression in terms of vaccine preventable diseases coming back. A lot of it has to do with vaccine hesitancy, which we'll talk about in the next couple of slides, but also the importance of lifelong immunization. So even if kids are getting inoculated against vaccine preventable diseases, what about adults, and how adults neglecting their shots could lead to diseases coming back. We look at a disease like measles. Measles is a very contagious disease. For those of you who've seen the movie Contagion, directed by Steven Soderbergh, one of the doctors in the movie, played by Kate Winslet, talks about something called an R0. And R0 is an epidemiological term that infectious disease specialists use to say, for every case of someone infected, how many more people can they infect? So with influenza, which is 'tis the season of influenza, which we'll talk about later in the presentation, the R0 is 1. One person infected with influenza can infect one person. Polio, before we had a vaccine, one infected person could infect 4 to 6. Measles, one infected person could infect 18 to 20. The air droplets from measles can stay in the air for almost 2 to 3 hours, leading to a lingering infection. So a very contagious disease, which there is a vaccine for. And there were excellent vaccination efforts. In the early 2000s, there was a very well monitored surveillance system that found that there were almost no measles cases. There were no new measles cases, and you can actually, from an epidemiological standpoint, the World Health Organization said its measles transmission has been interrupted in the Western Hemisphere. Now, this year, in February, we saw measles return to British Columbia. Combinations of people going abroad to underdeveloped countries and not vaccinating, bringing the disease back, and that in combination with low immunization rates in children who attend these schools led to an outbreak. A family of 5 traveled to Thailand, where they received vaccinations for food and waterborne illnesses like Hep A and typhoid fever. However, they declined measles, mumps, rubella vaccination due to concerns of its link to autism. When they traveled to Thailand, upon return, all 3 sons developed measles. And this was in turn spread to their school, leading to the outbreak we saw earlier this year. And then, of course, with Minister Dix allocating $3 million for additional MMR dosages to jumpstart that program. So what is this concept of vaccine hesitancy? Why do some of us vaccinate and some of us don't? What are some of the concerns? How does this all work? And I think the best way to describe vaccine hesitancy is it is a complex problem. So we look at this vaccine hesitancy continuum. On the far left, you see in the green, those who accept all vaccines. Those who accept vaccine, they receive vaccinations, they vaccinate their children, and they're completely for the intervention. Then you see accept but doubt. So those who get vaccinated, but at the same time, they have some doubts in terms of perhaps safety or how effective they are. And then in this large continuum, we see accept, delay, refuse. So some people sitting on the fence, and for a number of reasons, we'll talk about why they don't get vaccinated. And then on the far right, we see this, we see the tip of the needle, and no pun intended on that. We see the vaccine refusers, and then on the very tip, the vaccine deniers. Now, contrary to social media, this group is very small, yet they are the subject of a lot of controversy and internet memes. So just one in particular is, I think the anti-vax term for someone is kind of, it's got a negative connotation. So I prefer the term pro-disease. Now, given that I don't see any of you, I'm sure there's some laughters, but I don't, I'm staring at my screen. So I hope that there was some laughter across the audience. But in reality, as healthcare professionals who want to uphold public health and the betterment of society, we really want to address, and we play a critical role on the vaccine hesitancy continuum. So what sort of issues do we see? Why don't people trust vaccines and why don't they get vaccinated? Well, there's three domains, and we call them 3 C's. Complacency, so again, the perceived risks that it won't happen to me, and the risk of these diseases are low. So it's not the top on top of the individual's mind for health. There's other things that are more important. The second one is confidence in terms of, do vaccines work? Do I trust the science? And what about government? Who decides what vaccines are needed and when? And then the other thing is convenience. So health literacy, and of course, can you access vaccines? And one of the big things with pharmacists being able to immunize for the past 10 years, it allows an additional access point for patients to get vaccinated. So looking at complacency, it's the sort of the complacency around unaware or uninformed self-satisfaction. So what happens when we get too complacent with vaccine preventable diseases? Well, it can affect all members of our society, the old and the young. So in 2017 in the Okanagan, this is a picture of Aidan Pratt with his father. Aidan died of meningitis, a vaccine preventable disease where there's a vaccine that covers 4 strains of meningitis. Previous to this, the government only funded a Men-C vaccine for high school children in this province. Aidan died of a W135 strain. So after that, currently all grade 9 children get the quadrivalent meningitis vaccine. This is another case in Montreal where a young woman from a college died of a meningitis B infection. This is another vaccine preventable strain of meningitis, which is not covered by the government. It's a pay-out-of-pocket vaccine for meningitis B. And then, of course, we look at seniors or older adults, which are the most vulnerable members of our society. And one particular, given the season, is the impact of influenza on older adults. So unfortunately for seniors or older adults, they contribute to most of the hospitalizations and deaths from influenza. And one of the big concepts that I find that really resonates with me and my patients is this concept of immunosenescence. So as you age, your immune system ages with you. So this is a picture of a marathon runner by the name of John Starbrook, who is a very healthy 75+ individual who's running marathon races and complete peak of physical conditioning for somebody who's over 65. But when we look at marathon times, we see that people over 65 are running marathons. However, they're doing it almost an hour, taking almost an hour longer than their 20 to 25-year-old counterparts. And the immune system is the same thing. It's inevitable that the function and the ability of the immune system to fight infections will decline with age, no matter what you do, no matter how healthy you eat, how much you exercise, and even if you're running marathons, your immune system is not as good as it once was when you were younger. Unfortunately, older adults are not as healthy as Mr. Starbrook, with almost 80 to 90% of those over 65 having at least one chronic medical condition. When we look at something like influenza, I think we really underestimate the burden of disease. Not only does it contribute to over 12,000 hospitalizations and 3,500 deaths, but it costs the system a lot of money. So with the BC government investing in influenza vaccines, they're trying to mitigate cost avoidance from the hospitalization that can come up to almost $20,000. This isn't the only disease that has burden on society. So this is something called post-herpetic neuralgia, which is the potential complication of herpes zoster virus reactivation, also known as shingles. So most of us were exposed to chickenpox in childhood. After the primary infection, the virus lies dormant in the dorsal root ganglion of our spinal cord, only to, lo and behold, immunosenescence to take toll. At the age of 50, the immune system tends to dip a bit, and that virus can reactivate into our nerves. When it does so, it can cause permanent damage to the nerves that it's infected. And you can see what the cost is in terms of what that long-lasting, perhaps indefinite, post-herpetic nerve pain in terms of physician visits and hospitalizations and medications used to treat it. And then, of course, we look at antibiotic resistance. So we look at infections like pneumonia and even influenza, which when influenza infects the cell, when it enters, it replicates, and when it exits, it leaves the cell and it changes the glycosylation on the outside of the cell very subtly, but opens the door for Streptococcus pneumo to bind. It also causes damage to the lungs, allowing for a breeding ground for a secondary pneumonia infection. So if we don't utilize the full potential of vaccines, we're going to be seeing more infections and therefore more antibiotic use. What happens when these drugs don't work? So again, more antibiotics we use, the more resistance that we'll see. And the other thing we're seeing, probably that you're familiar with, is with our dental colleagues, our dentists are prescribing less antibiotics for minimally invasive surgeries, just to reduce overprescribing of antibiotics and resistance. In terms of, we can't, when we look at these data, one thing we can't ignore is what does it mean for the individual, for their quality of life, and that's something that's really hard to quantify in pharmacoeconomic models, but as an individual, you can appreciate this, is the quality of life that goes down after an infection of influenza or shingles or pneumonia. And this leading to that is the functional disability. So one thing that seniors, those over 65, value the most is their independence. And a bad bout of pneumonia and influenza, 15% can have catastrophic disability. You can see on the left, there's an individual, an older adult, lacing up their shoes, perhaps to go running, perhaps to run a marathon. And then on the right, it's a stark juxtaposition where the same individual is gingerly slipping on their hospital slippers. So one bad bout of these vaccine preventable infections can change the trajectory of this person's life. So the next domain of vaccine hesitancy is confidence. So what is the belief that someone can rely on something that works, and firm trust? So we talked about immunosenescence and how, going back to the flu vaccine or the influenza vaccine, this was a 2009 study done to see how effective the standard dose of the vaccine was in those over the age of 65. And you can see there's quite a difference between that gray line, which is those who are under 65, and the blue line for those over 65, meaning that the standard dose of the vaccine, the influenza vaccine that we see given out at publicly funded at health units, doctors' offices, and pharmacies for free, is not as effective for those over 65. So the standard dose vaccine has 15 micrograms of antigen, and there is a high dose vaccine, which is specifically indicated for those over 65, which contains 60 micrograms. And many of you may have seen this on the CBC News with BC's decision not to fund this vaccine versus Ontario, who has chosen to do so. And then, of course, the subsequent delay, that vaccine that's has better evidence in seniors is not available even to this date, maybe next week. But the publicly funded one that's available for everybody has been available for almost a month and a half now. But the main reason I want to highlight this slide is look at the level of evidence for this vaccine. And when we look back to Jenner's experiment of sample size of 1, no blinding, no ethics, where he's just poking some poor kid with an infected cowpox rod, we're seeing these now today massive gold standard randomized double-blind placebo-controlled trials with you can see the numbers almost. You can see the the last one, the retrospective cohort, being with each arm almost 3 million in each, so almost 6 million people over the age of 65 in the US were enrolled in that study. So we can see those numbers are quite high, and some of those outcomes are actually quite quite strong, not only looking at the disease itself, but what about the complications related to pulmonary conditions and cardiovascular conditions. Many of you may have questions from your patients or even for amongst yourselves who are over the age of 50, should I get the new shingles vaccine? And the new shingles vaccine is almost 98% effective in preventing shingles. And then, of course, there's the pneumococcal vaccination against pneumococcal disease. And again, looking at that sort of dichotomy that exists between what's recommended and what's actually free. There is a free vaccine for pneumococcal disease that only prevents invasive disease. And then there is a one that patients have to pay for that actually can prevent pneumonia infection in the lungs. So this just illustrates that vaccine, the conjugate vaccine, PCV13, in preventing first episode of community-acquired pneumonia. So this is the National Advisory Committee on Immunization. So those of you who are interested at looking at what vaccines are recommended by the experts in Canada based on the patient's demographic and medical history, you can Google NACI and they'll have a sort of a good resource to look at the data and what they recommend. But for those over the age of 65, the high dose vaccine should be used over the standard dose. And then Prevnar 13 is recommended for best protection against pneumococcal disease. And then Shingrix, dropping down to adults over 50, is recommended for adults for protection against HZV, also known as shingles. So that's just a bit of some of that new information that you may find helpful for your patients or your friends or your family. Let's move on to convenience. How do we access services and what is publicly funded? So this was an hygienist of Alberta, and they had a newsletter back in October 2017 stating, "Are your immunizations up to date?" And it's interesting because given your role and the contact you have with patients, it's important to make sure that your immunizations are up to date, not only to protect your patients, but also to set an example and be an educator for your patients and best practice. So these are the routine vaccines in adults. It is tetanus, diphtheria should be done every 10 years. Influenza vaccination should be done yearly. And then there's the HPV vaccine, which actually has no upper age limit. Now, given the time that we have, we won't be able to chat about this. And then meningococcal disease, we talked about that in terms of those under 25. Pertussis, 1 dose in adulthood, and then measles. For those, Vancouver Coastal Health recommends that 2 doses should be documented if born after 1970, with those born before 1970 presumed to be immune. So this brings us to our dental case. So this is a story about a young girl from Hawaii who was at a baseball game and playing on the bleachers at the baseball game, where she tripped and fell and actually hit her mouth on the bleachers. She sustained injury to her tooth and her gums, and there was a laceration. You can see that there in between the teeth there. There was a cut there. So she was treated, it was treated as a dental emergency, and they kind of treated the injury. But then something happened later on where she started having difficulty opening her jaw, and then she started having muscle spasms. And she actually developed a tetanus infection. And she was not immunized because her mother was not sure whether it was the right thing to do. Now, tetanus can be fatal, so the girl was lucky to have survived, but tetanus is a bacteria where the spores live on old rusty nails and old wooden sort of surfaces. So when she fell, the tetanus relies on tissue trauma. So anytime you cut yourself, you step on something, you go to the hospital or you go to your doctor, they typically give you a tetanus vaccination if it's been more than 5 years since your last tetanus shot. But she had no antibodies against tetanus, and as a result, almost died from the infection. And you can see that article in the corner here if you want to take a look at it in more detail. I would encourage you to do so. Okay, so the next thing I'll talk about is because it's the season, and we'll finish off here about talking about the influenza vaccine, which is, of course, probably of all the vaccines, the most controversial, probably because of its sort of lower vaccine or variable vaccine effectiveness, and the fact that you have to get it every season. So even healthcare professionals are in some cases divided on whether get this vaccine. So here's some examples here. So there's a Canadian who warns against apathy after flu sends him to hospital for 2 months. So again, one of the big things is this sort of misconception between the cold and the flu, in that, you know, the flu is sniffles and you may feel a little bit icky for a few days, but influenza is actually the worst infection that those individuals have seen in their entire lives. And those who've had influenza typically remember it for the rest of their life. And even those who are healthy can be significantly debilitated by it. This is a nice, very sort of powerful blog post that I came across from a blogger who hates getting shots, but talks about her friend James, who died of cystic fibrosis. And unfortunately, cystic fibrosis is a hereditary condition where the lungs, there's a lot of accumulation of fluid and secretions in the lungs. There's a sort of a genetic predisposition for transporters that typically help regulate this, but the lungs are so gunked with fluid that it becomes hard to breathe, and these individuals have trouble with infections. So this individual, her friend James, had a double lung transplant, helped him live for more than a decade, but then somebody who was not vaccinated against the flu. And that's one of the big things is even if we go back and we don't think this can happen to us, well, even if we don't become symptomatic, we can still spread the flu. And what the vaccine does do is it helps prevent the virus from bonding to and infecting epithelial cells in the nose and the throat, and talks about how her friend James actually passed away from a bad bout of flu. So again, not just flu shot maybe not be super effective and maybe a pain to get, no pun intended, but again, thinking about others around you as well. So this is sort of the last bit on recommended but unfunded vaccines. You can see here, these are the vaccines that are covered. You can see a lot that are funded for those younger children. However, those over the age of 65 get very little. So one of the greatest things we need to, I guess, dispel is that vaccines should be publicly funded or ignored. So if the government doesn't cover it, we just don't talk about it. And unfortunately, the reality is there is a lot of vaccinations that are beneficial, that have great evidence. Government can't afford it, so our patients are paying for many different health interventions out of pocket, and vaccines are now one of them. Again, a review of, particularly for those over 65, the trifecta of vaccines that they should invest in. Okay, so the last thing we'll talk about is international travel. So international travel is increasing 4% per year. And this, of course, is augmented by the fact that, that people are traveling to underdeveloped regions, and that's going up even more per year. So what vaccines should you consider when you travel? So I usually talk about travel vaccine. Well, before we talk about travel vaccines, the most important thing is you should be up to date on your routine immunizations. So your tetanus, diphtheria, your MMR, because look at that case of that returned traveler family back in 2019 who contracted measles. So once you're up to date on your routine immunizations, there's specific travel vaccines that are of particular importance. So this is a picture of Quinta, not only known for its beauty, but also in 2015 for the 29 cases of acute hepatitis A that affected returned travelers in the US. So these travelers stayed at a cluster of 9 resorts. Unfortunately, despite they were 3-star, 4-star, or 5-star, they did share the same staff who was infected with Hep A, and Hep A is a food and waterborne illness, so even ice cubes can be contaminated. Important thing to note, those who are symptomatic with Hep A were sick for up to 9 months. Again, you don't need to go too far to be exposed to Hep A. This is Union Station in Toronto, and if you had sushi at the Cali Love kiosk, then you may have been exposed to Hep A back in the summer of 2018. 2 travelers went to Mexico, did not get immunized. They were not symptomatic, but they were shedding the virus. And when they were preparing raw food, they were infecting people at a very busy city, at a very busy spot at Union Station. And they actually had a public health warning and advised those who were exposed to get vaccinated for Hep A.
Ajit?
Yes.
I just had a question about the previous slide, not the one, the Toronto station, but the previous slide with that one. Someone said the audio cut out. Where was that?
Oh, it was in Tulum, Mexico.
Tulum, Mexico.
Quinta.
Oh, Quinta. Okay, so
yeah,
a place where we often go to holiday.
Yeah, exactly. So, but yeah, and then so looking at routine vaccinations, we look at updating routine immunizations, tetanus, diphtheria, MMR, and then food and waterborne diseases, Hep A, typhoid. Dukoral is, I mean, I could talk about Dukoral for another hour, but it's a vaccine that prevents against E. coli-mediated traveler's diarrhea. So a lot of people call it a traveler's diarrhea vaccine, but it protects against one particular pathogen. And depending on how endemic that pathogen is where you're going, is whether it's worth the investment or not. Mosquitoes can cause disease, vector-borne diseases like malaria, yellow fever, Japanese encephalitis, and then of course animal bites, and not necessarily animal bites, but maybe animal abrasions. So in Parksville earlier this year, there was a young man who a bat ran into his hand randomly in the middle of the day, and he suffered a microabrasion, became bats are infected with rabies, and he actually developed rabies and died. And once you become symptomatic with rabies, then it's 100% fatal. Personal safety is something we talk about in all of our travel consultations, because in reality, the leading cause of death of travelers worldwide is not vaccine preventable disease, but motor vehicle accidents. So again, there is no price on common sense, but its value is insurmountable. So the last bit I want to talk about is some perspective. So part of our initiative at immunize.io is to take our best shot at vaccinating the world and supporting those where there are people still dying of vaccine preventable disease, hospitals full of children dying of disease, and mothers lining up for any sort of NGO, Bill and Melinda Gates Foundation sponsored or any other humanitarian aid organization to set up a clinic for them just so that they can get a vaccine to save their child's life. Unfortunately, many children are not able to get vaccinated, and the risk of death in those countries from vaccine preventable diseases is much higher. So again, we see lineups of mothers with their children, lineups for vaccine clinics, amazing efforts from humanitarian aid organizations. There's one particular village in Africa where when you want to vaccinate someone, a vaccine needs to be cold at a certain temperature between 2 and 8 degrees. So one of the big things we look at is maintaining the cold chain. So they actually used Coca-Cola trucks to get the vaccines in to this village. And then, of course, using new technology like drones, you can see on the bottom left there, to get vaccines to these citizens. And you can see here those lining up in clinics, and then, of course, the dichotomy. We see those individuals who are vehemently against vaccinating their children, saying, "My child, my choice." Yet there's, again, lineups of people on the other side of the globe just trying to get their children vaccinated. So I want to thank you all for attending today. I'm sure there's a few questions. I don't know if we'll get to time to all of them, but I did want to leave 15 minutes. So again, typically for our Immunize.io presentations, if we do get sponsored or there is an honorarium, we donate it to the End Polio Now initiative. And we also partner with Habitat for Humanity and make some donations there too. So thank you again for your attendance. And that's it for me. And if anyone has any questions, I guess I'll pass it over to Wendy.
Yeah, thanks, Ajit. I'll ask you the questions here. Some of the people are popping these. This is great having people can vote on questions and send them to the top. So I love this platform that we're using. It's got some great features. And thanks for that. That was a wonderful presentation. I'm just going to take back, just give me a few seconds here. I'm going to, so stop, yes. And I want to share this one. So this has, sorry, just a second. I'm not sure if I'm sharing the right screen here. I just need to double check. Yeah, okay, that's the right one. Okay, good. So there's my email. If we don't get to your question, please feel free to send me your email, your question, and I will ask Ajit and try and get back to you. So I'll go to the question that have floated to the top. Do you have any advice on how to talk to anti-vaxxers, particularly someone who thinks that it is just a money grab from Big Pharma, thinking that they are actually manipulating the vaccines they are giving you so that later on down the road they can make more money?
Yeah, no, that's a great question. I think that's one of the biggest sort of conspiracy theories that are out there. So the first thing is, again, we look at anti-vaxxers being a small subset. So the real target is those vaccine hesitant, and that's what healthcare professionals can make a huge difference for. So anybody who's overly difficult to convince, and you can throw every single fact and at them and they still won't be convinced. That's sort of the small tip of the continuum. One thing to remember is that this argument, to vaccinate or not vaccinate, it's not an argument. It doesn't have two sides. So it's either you appreciate the science and the intervention, or you simply just deny it or refuse it. So the Big Pharma argument is an interesting one because when you look at it's a very interesting concept because ultimately, in order to get treatments and vaccines, somebody needs to pay for them. And typically this is big pharmaceutical companies with shareholders. I think that pharmaceutical companies invest a lot to do research and development. The public tolerance for vaccines is very, very low. So again, it's kind of like I use the analogy of airplanes versus cars. Air transit is actually the safest mode of transportation. However, people still get very nervous about traveling on an airplane, yet they'll jump in a car no problem. The thing is when an airplane goes down, it's front page news, everyone hears about it, but people are dying in car accidents every day. So I think with the pharma aspect of it, it comes down to a more kind of getting that shift in terms of, well, who's going to invest in new treatments, who's going to run trials. These trials are very strictly regulated, and they're always testing it. And that the concept of vaccinology is pretty straightforward, and it's tested over and over again to be safe. And the other issue is in Canada, we typically, the Canadian funding decisions and pricing they set for medications, new medications, and for new vaccines is unreasonable. Their regulatory practices are much more strict than the US. So actually in Canada, we might not even get access to these vaccines and treatments. So looking at the flip side, also with the pandemic, if there's another H1N1, everyone who's anyone's going to line up to get vaccinated, but you only want it when you need it, right? So you do rely on these manufacturers to go out on a limb and fail and waste a lot of money and have to restart again the process. So getting an appreciation for that needs to help.
Right. Thanks for that. Here's another question. How beneficial is it for someone in their 20s, would you say, to get the influenza vaccine every year?
That's a good question. It really depends on their contacts. I think that we look at the sort of a U-shaped curve for influenza, and then those under 5, those over 65 contribute to the highest amounts of deaths from influenza. So I guess somebody in their 20s risk of complications or death from it is less. But I mean, again, like I mentioned, there's two things you look at. One, even with a 25% vaccine efficacy, that's the same as sitting in the back seat and putting your seatbelt on.
Right.
It's going to reduce your risk of death by 25%.
Right.
But when you look at a vaccine, you're like, well, why can't it be 100? So again, it's mitigating risk, mitigating sick days if you're 20 years old and you want to be productive. And at the same time, of course, looking at the bigger picture. So in BC, that 20-year-old would be entitled to a free flu vaccine if they had direct contact with somebody under 5 or over 65.
Right.
So if they're working in an old folks home, visiting or living with their grandparents, or had young children. So that's kind of where I would put it in terms of, obviously, I would encourage everyone to get vaccinated because that would reduce the burden of disease, but that's what the government prioritizes as funding.
Yeah, fair enough. This was a question that people asked in a variety of different ways, but this one kind of floated to the top. Can we discuss the controversy over heavy metals in vaccines that may have potential health side effects and the best ways to respond to this to people concerned about it? A couple of the other questions had mentioned mercury.
So it's actually not mercury, it's called thiomersal. And of course, thio is a sort of a mercury derivative. So some of the older vaccines had more preservatives in them. There's less so now. And actually the trace amounts of thiomersal in a vaccine is actually certainly less than a tuna sandwich, and actually less than a bran muffin. So the exposure to thiomersal is negligent with a vaccine.
Okay, good to know.
And actually, you can actually request thiomersal free. And the only vaccine that typically has it is the influenza vaccine. You can actually get a thiomersal free, because I know some patients do have a sensitivity to it, and whether it's placebo or not, we always respect that because it could change the decision to vaccinate. So ask your provider for a thiomersal free influenza vaccine, and they should be able to provide it.
Oh, great. Here's a question. Can you get the shingles vaccine before the age of 50?
So that's a very good question. So we're starting to see quite a few cases of shingles in those less than 50. And I think I personally don't recommend it because we don't have, first of all, safety data to know, we don't have data on that population in trials. But the other thing is we don't know how effective that vaccine will be, because when people get an episode of shingles, we actually advise them to wait a period of time, just because when you get it, your body is already making antibodies against it. And if we vaccinate too soon, it'll actually blunt the response of the vaccine. So for somebody who's over 50, we know that after about 8 weeks, we could re-immunize. If we want to be safe, we could wait a year. But in somebody under 50, we don't know how long that response is. So if someone has shingles and they immediately want to get vaccinated, is it even worth it? And is there going to be a response? So at the moment, it's not recommended for those.
Okay. Fair enough. Here's a question. Is it safe for pregnant women or women trying to get pregnant to get the influenza vaccine?
Yes, it is. It's actually a demographic who should be vaccinated against influenza, because if they get influenza, the complications are a lot worse. Again, all influenza products could be used for somebody pregnant. My patients typically want the thiomersal free. Personal preference, but again, the other one, the flu viral that does have trace thiomersal is safe to be used in pregnancy as well.
Okay, fair enough. Here's a question, and I did experience this as well when I went to get my flu shot. The question says, we seem to be having a shortage of the flu vaccine in our town. Is this happening in the bigger cities as well? Any suggestions to tell our clients on what to do and where to go to get the flu vaccine? I know we went in Kelowna for about a week without, no pharmacies had the vaccine available. And other questions, somebody said it happened as well in Victoria last year.
Mm-hmm. Yeah, so the shortage of the influenza vaccine, again, those issues typically arise with one, the World Health Organization tries their best to match the vaccine when it migrates from the southern to the northern hemisphere. So when it starts in Australia, they try and pick up any sort of last minute mutations that the virus would have. And there's been some success, because you recall back in 2014, the vaccine effectiveness was really low. And since then, it's been a bit better of a match. The consequence to that, though, is if they wait too long, manufacturers don't have a lot of time to quality control their batches. So again, the quantity coming out can't meet the demand. So it's kind of that sort of catch-22, is you want a better vaccine, but you also want to be immunized as soon as possible. That being said, for those of you who are really keen, you can sign up for Flu Watch, and you can see when the influenza virus spikes, and you can see its activity across Canada. So typically, you would see low activity, and you'd probably see it spike around probably pretty soon in the next couple of weeks.
Wow, that's kind of neat. You can actually see where it's happening.
Mm-hmm.
And now this is my husband. When I was talking to my husband about hosting this webinar, of course, you hear these stories, right? Here's a question. I've heard many people who got the flu shot for the first time and then got the flu more times than ever before that season. Is this a coincidence, or do you have an explanation?
Yeah, absolutely. So I guess the first thing is the difference between influenza and a cold, right? I mean, cold is caused by rhinovirus. Flu vaccine is not going to help you against that. If you had influenza, you would know it. And the other thing is, it's impossible for the vaccine to make you sick because it is not a live virus. It's just a picture of the virus, just so that your body can recognize what it looks like and make some antibodies. So one of the things that could happen is this superimposing of viral illness. So the flu vaccine takes about 2 weeks to be fully effective. So somebody could still actually get influenza in between those 2 weeks. And a lot of times they actually have a cold that becomes full-blown symptomatic around that time. So that's why if somebody comes for their flu shot and says, oh, I have a bit of a cold today, I say, it's still safe for you to be vaccinated. We're not going to strain your immune system. We're just showing you a picture. But I do want you to promise me that if you do get very sick in the next couple of days, it's probably because of that cold that's going to ramp up. It has nothing to do with the flu shot. So I encourage providers to reiterate that message. Because the thing is, when somebody gets sick with the flu shot, they just tell everybody. But if nothing happens, then they don't tell anybody. So I know.
I jokingly said to my husband, so that means that person had coffee that morning. So does that mean the coffee made them sick? Like, you know, the things that we link together don't necessarily go together, and yet people link them all the time.
Exactly. Well, it's causality. So again, you know, attributing events to vaccines. Actually, interestingly enough, you'll see in a lot of articles about vaccines, you'll see sort of anti-vaxxers post something about the vaccine injury fund in the US. And it's something that was put together in the 80s because what was happening is people were linking these causalities, and they were suing manufacturers, and manufacturers said, well, forget it, we're not going to make vaccines anymore. And the number of deaths from vaccine preventable diseases shot up. So they said they put together this independent sort of fund where if somebody felt that they suffered some sort of illness or disability from a vaccine, the manufacturer wouldn't be responsible for it. There'd be a set budget in US federal court that would deal with it. And actually, interestingly enough, 80% of those claims were thrown out because there was no causality. And then of those 10%, 20%, no causality was definitively found, but they settled just before court with the individual. So you can kind of see what sort of linkages. But yeah, with the whole with the autism, there's no biological link to autism. When you look back historically, there's more diagnoses because they expanded the diagnostic criteria that could lead to the data. But they see they see the spike in something, and then what is the common denominator for all those kids? Well, they all got vaccinated. It must be that.
Right.
So that's sort of the causality. Vaccines are a victim of their own success because they basically, when things are silent and quiet, that's when people appreciate them. Yet when there's noise around it, that's the first thing they turn on. Yet when these diseases come back and there's a pandemic, everyone's lined up to get them. So it's kind of that sort of logic.
Fair enough. Well, we're coming, or it's 8 o'clock, but I do see one more question here. A few people have voted on. Could you talk about HPV, as my son's class just had them, and I'm one of those that held off as I'm not informed enough about this vaccine. Any information would be appreciated.
That's a great question to end off with, because my cousins, my aunt and uncle actually opted out. They actually talked to their friend who was a nurse, and I actually convinced them and vaccinated her against HPV. So one thing we need to understand about human papillomavirus is it is a cause of cancer. And a lot of times it's kind of the whole, the whole sexual activity piece, because they're immunizing so early, that is sort of a confounder. But in reality, when you looked at my slides, it says there's no upper age limit. So human papillomavirus is a virus that is, again, of course, it can be sexually transmitted, but you can also get it from environmental factors, secondhand smoke, and again, it could just be idiopathic. But the key thing about it, though, is that it is one-third of cancer is preventable. If you look at individuals, my colleague works in psycho-oncology, so he deals with the psychiatric component of especially young people going through very aggressive cancer treatment. So if you look at something like head and neck cancer, for females it's cervical cancer, and again that sort of seems that's where all the attention is drawn to, is like, okay, I want to get my daughter immunized against HPV. But what we're finding now is that in men and boys, we don't have a cervix, but because we don't see a lot of HPV, our immunological clearance of it is very low. So it is now emerging as a leading cause of head and neck cancer in young men. So it's basically I call it a vaccine against cancer. Because again, I have patients say, oh, I don't engage in those activities, or it's not my kid. But in reality, it's, you're basically mitigating your child's risk of a vaccine preventable cancer. And for anyone who's seen it and go through head and neck cancer, the chemotherapy is brutal. And if we could take out something that could cause it just with simple routine vaccine, we have to go for it. And the World Health Organization has actually mandated that we do a global vaccine campaign for HPV, because we do have causality in our data, especially in a study in Scotland where we saw it drop HPV-related cancers quite significantly once the vaccine was implemented. So definitely again, you're just mitigating risk. Your kids are going to do things that you can't control, but you might as well take something out of the equation.
Well, thanks, Ajit. I think that was an excellent overview. I just want to close with one comment from Irene. She said, "Thank you, Ajit. You gave a very condensed overview of the vaccine world. I travel and do dental work in third world countries and see the strong desire for mothers to have their children vaccinated in Canada." I think she meant in Canada, we are so very lucky.
Mm-hmm.
So thank you.
And good for you for doing that.
Yeah, thank you very much. We appreciate your time. And I'm going to sign off for everybody this evening. And I'm sorry we couldn't get to all your questions. They were very excellent questions, and I wish we could stay on here all night, but I know everybody is probably tired and has to go to work tomorrow. So we're going to sign off for this evening. And thanks again, Ajit. We really appreciate your time.
Yeah, thank you all for your attention. Thank you.
Okay, good night all.
Okay.